I think we are live now. Hi, everybody that's following both on Facebook and the webinar. This is Melissa. We are coming to you. Dr. Farma and I tonight is my special guest. Dr. Farma is a well-established surgical oncologist. He actually is the chief of the Division of General Surgery and the co-director of the Melanoma and Skin Cancer Program at the Fox Chase Cancer Center. I'm very blessed that he agreed to come on here with me to talk about, basically the surgical recommendations and guidelines that we're using now for this whole COVID nightmare that we have going on right now. He's also the program director of the Complex General Surgical Oncology Fellowship and part of the Molecular Therapeutics Program at Fox Chase. So we're very blessed to have him here with us. He's won so many awards, and so hopefully we'll be able to get a lot of our questions answered and feel a lot better about how things are being managed surgically right now. We're going to kind of go through the things that we plan to talk about tonight with everyone. And if you have questions, there's a question and answer button that you can submit questions online. We'll try to handle as many of those that are relevant to the topic that we're talking about tonight. Kathleen is monitoring the questions over, one of our associates is monitoring questions over on Facebook Live, so we can get questions from both sources. Please don't be afraid to ask questions. We'll be able to answer as many things as we are able to online here. So, Dr. Farmer, do you have anything you want to add before I get started with my little interview here today?
Melissa, thanks for having me. This is all, it is a trying period for all of us, and there's ups and downs, and it is really hard for everything, the guidelines for melanoma or social distancing or how we treat patients in the hospital. I think it's difficult even as a provider to follow because things change on a daily and weekly basis, and it's a little hard to keep up. Thankfully, at least where I am, and it sounds like where you are, things are starting to normalize, although not completely normal. And so I think it will be a really interesting discussion to talk about kind of what the safest approach is for managing the patients with melanoma, how we can alter things if needed based on the environment where you're being treated, and what you should look at as a patient, and what questions to ask as you should be treated as safe as possible, with both the concern of the melanoma, which surely we are all concerned about,
right?
Also with COVID. So I'm looking forward to the questions.
Good, and that's kind of where we're coming from, because right now we're in the situation where melanoma doesn't stop happening, so we have to kind of figure out the safest approach. And I wanted to start off kind of talking about, so the NCCN is this, well, the way that I see them is this big collaborative group of melanoma specialists and oncologists and surgical oncologists and whatever, that kind of get together and look at literature and kind of how things are managed currently. They look at, the environmental factors and how we need to manage things. And actually most of our recommendations, just for people that don't know what the NCCN do, they really are the board of people that make the decisions for each specific disease state and what the standards of best practice are. I know, especially even when we are getting people financially ready for certain things treatment wise, we defer to the NCCN guidelines for financial institutions to make sure that they approve them. So when all of this COVID happened, I know the NCCN met. They made recommendations, at least initially, about how we should be dealing with each stage of disease. And so I just want to kind of start by talking a little bit about that. I know things have kind of changed from where they started. So if you could speak to sort of what is new in managing surgical cases, that would be helpful.
Yeah, the NCCN number one, is a great resource for patients, I think, for all disease sites. And so the melanoma panel has really done a great job and was really at the forefront when the pandemic really was, first started coming out with these guidelines. And they've come out with 3 versions now. So we're on the 3rd version. They've changed, as I said, it's a change in paradigm. And they've adapted as this is unfolded. I think they really did a nice job of breaking it up into different kind of degrees or from biopsy initially, if you have a lesion that you're concerned about, what should you do? And that going back to all the things that we always talk about for melanoma, the A, B, C, Ds, and E's of melanoma that all patients should be aware of. Right now, you may not be able to get into a dermatology office. I think a lot of them are starting to open up and see patients or your primary care doctors. And this is really where melanoma is first diagnosed. And so if you do have a lesion that's concerning, irregular shape, change in color, evolution or the lesions changing, bleeding, itching, anything, a lot of providers are doing at least televisits now. And so
Right.
even if you were concerned and you were in an environment or a city where you couldn't get in right away, you likely could get in to at least see a televisit to maybe decide that, well, maybe this isn't, and not, televisits are not 100%. It's not like seeing patients in person, but you could at least have a lesion at least identified or take a picture and send it to a provider and determine how, is this something that really you can sit on, or if really it needs a biopsy. And so the first part of the guidelines really looked at how best to biopsy patients and in the safest way. And so normally we would do shave biopsies or punch biopsies or excisional biopsies with narrow margins. So where we just take a small rim of normal tissue around the lesion. And so all of these things the guidelines really looked at and recommended doing these types of biopsies. And if a patient is diagnosed with melanoma and has a biopsy, then it's important to have those biopsies evaluated, and that really kind of allows you to determine the best next course of action in regular times or COVID times as kind of how best to approach the lesion. So the first set of guidelines really looks at biopsy. So they recommend either an excisional biopsy or shave biopsy, and really looking at the pathologic criteria. So if a lesion is fully removed on that biopsy, even if it is a melanoma, it may give us a little flexibility in terms of the urgency to manage a lesion. So if we know that all the cells are out and there's no remaining melanoma and it wasn't just partially biopsied, it may give us a little more buffer to make a definitive plan, especially if you're in an area that has a high COVID incidence currently, or you can't get into a hospital safely, or you can't get in to see a provider.
So, so when you're looking at like folks trying to get the, initial biopsy, the recommendation now, instead of trying to remove just partial part of the lesion, they're really looking at trying to remove as much of the lesion in question initially, correct? Would that be correct?
I think that would be ideal. So if normally you would have a shave biopsy, you may have an excisional biopsy, so the lesion is completely removed and then can be evaluated by pathology. And then really, like all of the things that we normally look at pathologically for melanoma, how thick the melanoma is in millimeters or the Breslow depth, all of those things can be evaluated, or high-risk features, like if it's an ulcerated lesion or high mitotic rate. Or also if the lesion's biopsied and the margins are positive, then that may alter or change kind of how we end up managing this, where possibly you would just go in the office and have another excision to make sure it's fully removed before you could go get in, even to consider sentinel lymph node biopsy, depending on where you are.
Yeah, and I think there was a question from one of our viewers asking, do you recommend biopsy by an oncologist or surgeon, or is a dermatologic biopsy for the initial diagnosis okay? And I don't think that's changed. I think we will accept biopsies from whoever feels like they can take them, I think.
Correct. I mean, throughout the country, melanoma is diagnosed in all different venues. So I would say I do not diagnose melanoma very commonly. Most patients come to me after being seen by a dermatologist or a primary care doctor and have a diagnosis and biopsy. So I don't think the mechanisms of surveillance and identifying melanomas and biopsies have changed. It's just a matter if you could get into an office and be seen by a provider to get that biopsy. And if you can't, then you can, you definitely can also be plastic surgeons, surgical oncologists, general surgeons. All these type of providers can perform biopsies. So,
right. So let's say, okay, now we've been diagnosed with the melanoma. It was completely excised, but does require a sentinel node biopsy. Originally, when I had looked for the NCCN guidelines, it looked like they were saying like you could delay these sentinel nodes up to 3 months. And I know a lot of patients, because I manned, the Ask an Expert question line for AIM, I had gotten a lot of questions about like, is this really safe? Is this something that I should push my oncologist to do sooner, or a surgical oncologist to do sooner? What are your thoughts about that time frame?
Along those lines, so there's a couple of things. So the thickness of the melanoma kind of predicts how commonly or what percentage rate the sentinel node would be positive. So a very early lesion, like a state T1 lesion, that is a 0.8 millimeter melanoma, probably has about a 7% chance of having sentinel node positivity if it's not ulcerated. And if you have a really, really thick melanoma, that can increase up to 40 or 50% chance. And so for the earlier melanomas, the guidelines had recommended potentially, as long as the lesion was completely removed, the melanoma, that you could delay sentinel node biopsy. A sentinel node biopsy is a diagnostic test. So it's a way that we, using a technique with small incisions, that we can identify and remove the lymph nodes that have the highest chance or probability of cells breaking off from the melanoma and going to those lymph nodes. And it does give us a lot of information and is very important in the staging of patients with melanoma and determining kind of next steps of care, if that is taking out more lymph nodes or following those lymph nodes with ultrasound, or offering other adjuvant therapy like immunotherapy or targeted therapy with BRAF and MEK inhibitors. So the sentinel node biopsy is surely important, and none of these guidelines are de-emphasizing that. However, if someone has an early, even a T1 or T2 melanoma that is not a very, very thick melanoma that we think probably has a lower percentage of having a sentinel node, we don't have great data on this, but it's probably safe to wait 3 months or so, depending on where you are, on undergoing surgery, because that operation needs to be done under general anesthesia. It is an outpatient operation, but you still have to come into a hospital. You're seen by multiple providers, and depending on the level of safety of that hospital and the level of COVID cases, that could put you at risk. That is probably higher than not having the sentinel or delaying the sentinel node. So you have to be mindful of that.
Right.
Studies from China have shown for all surgeries that if someone does have coronavirus and is operated on and we didn't know about it, and then develops symptoms afterwards, that there is a much higher risk of complications after a surgical procedure. And now they didn't break it down into melanoma procedures or abdominal procedures or other types of operations. However, we do know that we really don't want to be operating on someone that has coronavirus that we don't know about.
Sure. So would you say, and I know that at our institution, but we're a big academic center, they're testing pretty much everyone couple days prior to surgery, to ensure that they are COVID negative. I know some community hospitals can't do that, but it seems like that's a general recommendation for really any kind of procedures, at least at this point.
Right. So the American College of Surgeons and other national guidelines have started opening up in different regions, like we're all reading in the news, the green and yellow and red areas, and so that we can start doing more elective surgery. And from the get-go and start of all this, cancer is not elective surgery. We fully recognize, and our priority and my priority as a surgical oncologist is to treat my patients for their cancer as quickly as we can, as all providers are. So it's not elective surgery. However, we have to be mindful. We were initially very, very concerned about resources with protective equipment in hospitals, if we were going to need ventilators in the operating rooms. And so everything really, really shut down immediately. There are still some areas where the numbers are going up and not going down. Thankfully, a lot of peaks have occurred where we are able to start operating again and doing cases. As you said, Melissa, at where you are, we're testing everyone. So everyone undergoes COVID testing 48 hours prior to surgery. If they undergo testing and are found to be positive, most of these are asymptomatic, so you didn't know you had it. But I personally have had multiple patients that have come with a positive testing, and then we delay surgery for at least 2 weeks and retest prior to undergoing surgery again. So that is occurring. But I think that the COVID tests are all different, and there's different ways that those tests are done, and nothing is 100%. But I do think the preoperative testing does give us a little security for both the providers and our staff, and also for the patients we know that we can't make the risk zero, but we're making it as safe as possible. And also recognizing that we have to treat cancer.
Sure, and that leads us to, the next kind of thing I wanted to talk about, because, we have patients that are completely terrified to have surgery, to come in for their treatments, to get their routine follow-up visits. And so, what kind of recommendations do you have for those patients going into their visits to protect themselves or to prepare for those types of things?
So it all depends, every hospital has their own guidelines.
Right.
Where I am right now, we are very cautious we really limit the amount of visitors really who are coming into the institution, which is tough. But we do we are maximizing as much as possible phone calls during the visits, or FaceTime, or virtual, or visits where we can include all family members that need to be involved. So we're really trying our best, and we fully recognize that's not an ideal situation. But as a cancer hospital, we need to limit as much as possible coronavirus coming in, because we have a very, very sensitive population that is at increased risk
Right.
if it comes in the door. So I think patients, and we're screening everyone with temperature, and everyone wears masks when they come into our facility. You want to be careful about touching too many surfaces. You want to social distance like you're doing everywhere else. So our waiting rooms are arranged where they're spaced out. We don't have long wait times. We get patients in and out, and really try to increase our throughput to limit exposure to staff, to limit exposure to other patients. So I do think it's becoming safer, not 100% safe, to come into visits if your providers are able to do that. The other options are televisits or video visits. And that certainly is an option. I think it depends on what's going on. So if someone clearly has significant symptoms or really needs a physical examination, the televisits and virtual visits are very, very difficult. We still, especially for melanoma, want to do a skin evaluation. We want to palpate lymph nodes if it's in the armpit or neck or groin, and that is impossible to do in a virtual realm.
Right.
But patients who are either being followed and have no symptoms and are just for surveillance, you can at least check in on them. You can evaluate things via that virtual arena. If patients are getting scans and are being followed with imaging, they could come and get their scans, and then we can review the scans even visually and share the screen and look at scans to make sure that everything is okay, if it's a routine kind of surveillance with imaging. So there are different options. You just want to be as careful as possible. If you had an early melanoma and you far out from your diagnosis and you come for yearly visits, it is completely safe in my mind, as long as you're not having symptoms or you're not concerned about everything, probably to delay the visits for a couple of months until this settles down a little bit. I think that there's very, very minimal risk to that. However, if you're having symptoms, if you have a new lesion, if you have headaches, change in vision, if you have new back pain you're concerned about, and you have an advanced melanoma, if you have new swelling in an extremity, any things that are really concerned, you definitely should reach out to your provider. And that may warrant a face-to-face visit as safe as possible.
Sure. We had another question kind of related to that comes up a lot. Sam had asked on our question and answers, does having surgery put you at higher risk of COVID? Now, I know you already touched on, like, if you're asymptomatic and you go into surgery, there's a higher risk of complications. But, like, I think a lot of patients have concerns about, out there information wise, is that, like, having a surgical procedure makes you a slightly immunocompromised. And so, having lymph nodes out, having the completion node dissections does that make you more at risk for COVID? Are these folks actually immunocompromised? Now, I spend almost all day talking about how this is not the case, but it would be very helpful for you to weigh in on that.
Sure. I think the chances of that are very, very low. Surgery definitely does affect the immune system. The duration and the extent of the surgery is different in everyone. I think if you're doing an excision and a sentinel node biopsy, it probably is a very, 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 very small risk that it would lower your immune system that much and increase your risk dramatically for COVID. I think that's a much lower chance. Bigger operations that take many hours in the operating room, which thankfully and generally are not the case really for melanoma patients, may increase your risk because you do have abdominal surgery does decrease your ability to take deep breaths. It may increase your risk of having some pulmonary problems. And if on top of that, you got coronavirus, that could potentially lead to more serious complications. But I don't think surgery alone dramatically increases your risk of being susceptible to coronavirus. But like anything, I think that, you need to maintain wearing masks in public spaces, trying to limit going out to public areas, being careful of surfaces, and probably most importantly, wearing masks and washing your hands.
Yeah, exactly. It's funny how these recommendations haven't changed in 100 years for all types of viruses, but they seem new to everyone.
Right.
One of the things that I get asked a lot too is, I'm assuming obviously someone tests positive for COVID, you're delaying their surgery. If a household member were to test positive, but their initial 48-hour test was negative, would you still proceed at that point, or is that something that you would want to delay as well?
Right, so if it's a close contact, that's a good question, and you'd really have to consider. And also, we don't have all the answers. I wish we did.
Yeah,
right. Some of it is really a discussion with your comfort level, and if your close family member tested positive and you're living in the same house, then the high likelihood is you're exposed. And there's a chance that your test is what we call a false negative test, where it may take time to show up on the test, and it may have just been. So you may want to delay surgery if that was to occur for a week or two. And as much as everyone gets very anxious about a cancer diagnosis, the reality is even in the most advanced cases, usually 1 week in either direction of waiting or being treated doesn't generally change the outcomes in patients. So It doesn't mean that suddenly your melanoma in 2 weeks is spreading to the lymph nodes or spreading elsewhere in your body. I think it's very exceedingly unlikely that occurs based on many, many years of experience. So
that's really good information, because you will have no idea how many times in one day that comes up. We try to explain it even as oncologists with treatment plans that, your melanoma is not spreading in days, it's spreading in weeks and months. And so, not that we don't want that urgency and that sense of getting started and doing things as much as and as quickly as we can, especially in the era that we're living in right now. We also have to take all of the other considerations into factor.
Yeah. And I think just to put it in perspective, normally, so when I'm full volume, I have a very, very busy clinic. I see a lot of patients. I do a lot of operations. And unless someone is exceedingly anxious, my general time from seeing someone with a new diagnosis of melanoma to operating is on average about 2 to 3 weeks. And so It's not always that we rush into surgery when you have a diagnosis of melanoma. So this doesn't necessarily change that. It actually is allowing patients to get in. If they are coming in now, we actually get them in pretty quickly because we're not as busy and we're not fully up to capacity yet. So, but I don't think ever waiting and just making sure things are okay, especially thinking about coronavirus, and talking to your provider and really making an informed decision between you and your provider is the best option to consider.
So when would we want to contact our oncologist with symptoms, that would, because, with the types of surgeries that you're having for melanoma, you're not seeing most, you compared to an abdominal surgery, like post-abdominal surgery, people with shortness of breath, like I'm sure the surgical oncologist is thinking could be a pulmonary embolism, could be atelectasis from, collapse of the lung from putting in the tube. There's a whole bunch of post-operative complications that, seemingly are from just the surgery. So at this point, I would assume if something doesn't seem right post-surgery, you should call. Like those things haven't changed. We're not, changing our recommendations for
Right,
that.
and everyone's very, at least in my practice, and I think most practice, very accessible. Everyone who leaves us is instructed to call immediately with anything. Most of my patients actually have my cell phone if they need it for emergencies. But, you have to have open lines of communication with your provider. And if there's any concerns after surgery, redness, fevers, drainage, new swelling, shortness of breath, chest pain, we want to know about it and determine the best option. And really, we've devised strategies really to, if we need to evaluate those patients, what is the best mechanism to do that outside of the emergency room? So there are situations where patients 100% need to go to emergency rooms right now. But if we can bypass that and come to a office visit, because I think that does potentially decrease the risk of coronavirus if you can avoid an emergency room.
Yeah, I know a lot
Sometimes
of times we're seeing patients in our office rather than sending them to the emergency room.
Right.
Like I'm doing more urgent care visits now than we were before because of that reason. So,
but I do think the televisits in that setting actually have improved care in the post-operative setting, and I think, and I hope that we're going to utilize what we've learned from coronavirus in the future in how we manage patients, because sometimes you can just look via video conference and determine that, no, your incision looks fine, you don't need to be seen, or maybe you need some antibiotics and I can prescribe it. So I think it has opened up. That's one, we're learning new techniques and options through this whole experience that I think there are things that we will utilize and take from this as positives.
I wholeheartedly agree. I think telemedicine, even from, we obviously do melanoma medical oncology in our clinic, and telemedicine has been a blessing. And it's something that I hope that we're able to carry on. I mean, for even patients that come from out of state with scans, they drive 5 hours to come and just learn what their scan review is when we could 100% do that via telemedicine. So I think it's opened a whole new world of being able to care for our patients actually a lot more efficiently. So hopefully that will continue.
From a financial perspective for the patients, from a time perspective, I think that there's a lot we'll be able to learn from this and change how we practice, that's a good thing.
One of the blessings that came from this whole debacle, I guess.
Right.
So when do we think that, obviously there's no time frame on this. So I think we're continuing to kind of evolve as things move along. We've kind of coined the term pivot. We continue to pivot as things change. So, these NCCN guidelines and sort of how people are managing things seem to be continuing to evolve sort of as the country is evolving back to normal. So I guess, one of the things that patients want to know is, do we foresee, how far into the foreseeable future do we see things being this way? I feel like there's not a really great way to answer that question. I think it's
I think that's a really, really tough question. I don't have a crystal ball, and I wish sometimes I did for a lot of situations. I think that I think each region is different. So, and each hospital system is different. And so depending on where you live and who your providers are, that's going to be different. So whereas we are really, we were very lucky at my institution and we are approaching getting back to normal, I think that there's still a lot of centers that are not there. And so it's really just going to be in your region, the number of cases. Then if there's, and the things that make the question even harder to answer, if there's a second wave of peaks in coronavirus, all those things we don't know. But I think that these guidelines allow us to, and they're guidelines, they're not set rules. It gives us some leeway to alter how we would normally treat patients and gives us other options that were designed by experts that we feel are safe. And so it gives us those to fall back on. But as soon, every institution wants to get back to normal and go back to our normal set guidelines. So it just really depends on where you are and the options for treatment and also the safety of the institution where you're being treated.
Sure. So what does your institution have planned for, like, the backlog of patients that couldn't get in during this whole, period of time where we were really restricting the people that we're seeing and kind of pushing people back? Do you guys have a plan moving forward? Because I know where we are, we're just gonna see everyone. We're gonna see as many people as we can possibly see in a day and try to catch ourselves back up to where we are. Like, we're not planning on pushing everyone back. We're kind of keeping the people moving forward that are able to come in and trying to fill in the slots where we can see people. I mean, there's only so many things you can do in a day, obviously, but
right. I mean, we haven't opened up more clinics per se. Our melanoma survivor clinic likely will start seeing more patients than they normally did. We're gonna go back into kind of our surveillance strategy that we were in, and our new patients are being seen, as quickly as possible. But I can't say. I think that's probably the strategy of probably most institutions. I agree. There's only so many hours in the day, and we're not opening we're not doing nighttime hours or weekend.
right.
And I hope that's not the case. I think that with time, it will equilibrate and we'll get back to a normal. When that is, if that's 3, 4, 6 months, we don't know.
Yeah, exactly. That's what we just are kind of like, well, we'll do what we can and just kind of hold on for the ride is kind of where we are. And I think really the take home message here is just the more communication that you have with your oncology and surgical team, the better you are. And if that line of communication is not open, I'm like, I man this Ask an Expert line. I'm always willing to try to help and answer questions. I know, we get a lot of calls from other folks that are seeing people in community hospitals kind of everywhere. And we try to help those people as much as we can. So I think, the take home message for me is if that line of communication isn't open with your current provider, find another one that can help you. There's lots of resources.
I feel very strongly about the patients being their self-advocates. And so if there is something that you don't feel is right or you don't feel safe with or you're very concerned about, you can be evaluated. It's just, it may take some phone calls or looking around or finding or a little travel, but you definitely can be evaluated. I don't think nothing has shut down completely where if you have something that you're very concerned about, if you have a new lesion that you're exceedingly concerned about that's changed and is bleeding, you need to see someone immediately and get it evaluated. None of us are saying that we should wait 3 months and delay a new diagnosis of an advanced melanoma. That's what we really, really want to avoid. We want to do things as safely as possible, but you still you shouldn't just because you call and you can't get into one office doesn't mean there's not another facility or availability that you could be seen by someone.
Sure. So I think that's so important. We try very, very hard, especially like where I clinically work, but also at AIM, to try to provide patients with as much information, to education and resources to get help. So, all you people listening out there, if you're not getting help where you're being treated now, please reach out because there are folks that will help you find them. So, is there anything else, that you want to talk about?
I know a little bit about more advanced melanoma. So there are some situations I think that the guidelines are kind of interesting and I think kind of brought to the forefront of that we could do this right now because we think it's safe, but then it actually may be how things are going to move in the melanoma world in the near future. So if a patient comes in and has large lymph nodes that we feel, or in transit disease where nodules are growing in the extremities or elsewhere in the body away from the primary melanoma called in transit disease, These are definitely concerning situations. And so if someone presents with lymph nodes, our general recommendation, if there is no evidence of spread elsewhere in the body or metastatic disease, we would recommend resection and a lymphadenectomy, or removing really all the lymph nodes in that basin or region where the lymph nodes are involved. The guidelines actually bring up that we could do what's called neoadjuvant therapy, which is actually treating patients first with either immunotherapy or targeted therapy or BRAF MEK inhibitors prior to undergoing surgery. So this allows us to basically hopefully treat the melanoma and shrink the disease and initially delay surgery, because that was the #1 risk. Now, I'm able to operate now and operate on these patients. And neoadjuvant therapy, we haven't had large clinical trials yet to do this, although there are clinical trials that are ongoing. And most providers in the melanoma world feel that this likely will be the way that we treat patients in the future. But right now, we're really, most patients that we have done this on are on a clinical trial, which I feel very strongly about. We need to not just willy-nilly change whole practice guidelines on a couple of cases, and we need really good data when we make changes in the future. But I think that there's enough data out there that allows us to, in these guidelines, to recommend that if you can't undergo immediate surgery for advanced melanoma, well, we could treat you with a short course of therapy to your whole body and then do surgery afterwards. So I think that's something that came out of the guidelines, which is an area that I think a lot of melanoma physicians are really excited about, and that was put in the guidelines, which I think is interesting.
Yeah, and I know that a lot of the smaller centers don't have those neoadjuvant trials available, so it at least gives them a little bit of leeway to be able to do that if they aren't able or don't live near a place that has the neoadjuvant, trials that are open right now available. Because I know, a lot of the folks that come to our center have come there for neoadjuvant treatment from hours away because they didn't have it available. So, but at least under these times, that's been very helpful. We've also seen that with like the approval of pembrolizumab every 6 weeks. That was something that was not in the foreseeable future until all of the COVID happened. So it's something that I think is extremely helpful to those smaller centers.
Right. And I think the other thing, so if a patient has a positive sentinel lymph node biopsy, so if we find melanoma cells in the sentinel node biopsy, the paradigm changed about now 2 years ago or 2.5 years ago, where we either could offer a completion lymph node dissection and do surgery to remove the lymph nodes, or ultrasound surveillance, where patients come in every 3 to 4 months with an ultrasound of the lymph nodes, which gives us a finer evaluation of the lymph nodes to look if there's any changes and are concerned for melanoma. And the COVID guidelines really, again, highlight that we likely can safely watch patients with ultrasounds rather than going to surgery right away, even if we are considering doing a lymphadenectomy. We still do lymphadenectomies, and that's a whole nother discussion, and we don't have to go to that, but I think that this at least highlights that if you're considering undergoing lymphadenectomy, at some point you probably can watch with ultrasound for 3 months, even if you were considering, or the recommendation is to do that. So.
And you bring that up, these recommendations are based upon data that they actually have. So that's something that, I definitely wanted to highlight, because, I know when the guidelines first came out, they just kind of thought that these were arbitrary things that people decided, but really they're based on many years of trends and data that we've seen. So I think one of the things that I want to impress upon patients is that, the decisions that are being made during this time are really in your best interest from all aspects. It's not something that, these are new ideas. These are things that have been happening in centers for a while. They're just being more widely, supported, I guess, is what it kind of seems like.
Exactly, yeah. And then I think lastly, the guidelines talk about what we call metastasectomies. And that's
Yeah,
where we go and remove metastatic spots of melanoma. And there are definitely patients that have a survival benefit or live longer if we can go and remove specific lesions. Now, melanoma it has changed dramatically, even in what I consider my short career. And in the last 10 years, we are seeing responses to therapies like the immunotherapies or BRAF inhibitors, things that we would probably never even have imagined were possible, which makes all of us all of the providers who treat melanoma exceedingly excited about where the field of melanoma is and also the possibilities of where it's going to go, because really this is like the first wave of treatment options. And my hope is in my career that it even gets better and better and better and better. But surgery is still an option for patients. So if there's one spot that is still persistent after being on systemic therapy and we can remove it and to make it so that there's no other lesions, that's a completely reasonable strategy for metastatic melanoma. In the setting of a multidisciplinary team that discusses this in a multidisciplinary setting where everyone is in agreement and things of that sort. But during the COVID era, I really would probably delay that unless we're considering that unless it's for symptom or palliation of symptoms.
sure.
So if a patient is having significant pain or discomfort that we could correct with surgery, then that is potentially reasonable. Now, sometimes we can give a dose of radiation that can affect that as well. That may be a better strategy than undergoing these tend to be much bigger operations than metastasectomies for melanoma. And so those are things that you have to discuss with your team. But these guidelines highlight that as well.
Yeah, that's what we're seeing, a lot more radiation, especially stereotactic radiation used for these metastatic lesions, especially like bulky lymph nodes, lung nodules that before we would have referred for surgery. A lot of the surgeons are electing to have those patients, evaluated for radiation when possible as well. So we're definitely seeing that trend here too. Does the same thing I know this is kind of probably outside of because it's neurosurgery, but are these same type of guidelines being applied in a neurosurgical setting?
Yeah, I think that's a very unique. So when patients present with metastatic melanoma to the brain, as you know, it can be very concerning. And I think it really is dependent on the presentation. So if a patient comes in and is having significant symptoms, change in vision, has recently fallen, and has an MRI that really has a large lesion with a lot of edema or has bled into itself, then a lot of times I think that they would still need surgery. And I think that's more of an urgent or emergent situation than an elective operation. And that probably has not changed based on COVID. I think those patients likely probably need surgery.
Sure.
On the smaller lesions that are asymptomatic and have brain metastasis, I think then that leads you to potentially consider a combination of systemic therapy and radiation in the setting of probably seeing or even having a virtual visit with a neurosurgeon to discuss options. But if you're asymptomatic, it probably does not need to undergo surgery. But those you really need to be seen by experts who manage this commonly.
Sure. One of the questions that had come across the question and answer thing was, how often have you met for reevaluating the NCCN guidelines? As we earlier mentioned, it's been updated several times during COVID. I don't know that it's necessarily like a set of schedule. I think as more information is becoming available, it seems like that's how the recommendations are sort of happening. I don't know if
Yeah, I think this is more of a fluid process. Normally the NCCN guidelines meet either yearly or biannually to update the overall cancer guidelines. So depending on which panel it is, there's a different frequency of how often the guidelines for melanoma are updated. These COVID guidelines were kind of an ad hoc guidelines that were put together very quickly. It was actually amazing how quickly these came out. And then they've adjusted them as things have evolved. I don't think that there's a set schedule on when it's being reevaluated. and hopefully, maybe we won't have to get to version 4.
Yeah, that would be really nice, huh? Everything needs to go back to normal sometime soon.
Right.
We had a chat question. Let me see if I can get to it. There's like 100 things happening at the same time. So it's a question from a woman named Debbie. She said she's finishing her clinical trial year and had a partial response with some early shrinkage and growth. It's an axillary lymph node and hasn't yet spread. She's now trying to consider surgery. Are there any other options or things to consider with timing? I think you kind of covered this a little bit in your, in what you just talked about, but if you want to clarify that for her.
Right, so I think it depends, one, where you're being treated. So, and this, I can't, it depends on the region and what the hospital resources are and what are the availabilities of, what cases are being allowed to be operated on. I think the safest thing, so if this was occurring tomorrow in my hospital, and there's only an axillary disease, this is regional spread, and so the normal guidelines outside of COVID, we would plan on a surgery to remove the axillary lymph nodes or axillary lymphadenectomy. Right now, I would be able to do that at my hospital, and that's what I would recommend. I think you could, waiting a couple of weeks is probably safe. I think it's, if you can undergo testing prior to surgery, that's probably the safest option. But you could explore other clinical trials, or you could explore other systemic therapy, are potential other options to discuss with your provider. But the standard probably, if on this clinical trial, would be if this is the only site of disease, I think it's probably not a rational decision to have surgery.
To rush to surgery, right? And I know a lot of, to answer this question from, medical side for patients that we have in situations like this, a lot of times if it's possible for them to continue the clinical trial, we've gotten some deviations that allowed folks to continue past, the end point of 1 year or whatever the end point of the trial has been set at. A few patients we have transitioned them to standard of care treatment to kind of buy them a little bit of time until they're able to have the surgery. Now, again, just like you, we don't have that issue at our institution, but we're a big institution. And so folks that are having surgery at other smaller places, you just need to talk to your oncologist about it. There are ways around it, essentially, is what everyone's saying.
And if surgery is not an option right now and is an option in 6 weeks, you could switch therapy. So they should check for BRAF and see what the other potential systemic options are. So
sure. So there's lots of options. Again, goes back to talk to your doctors about it. I think that's the best advice we can possibly give to everyone.
Yes.
So I think here's another question. Everything just is like all of a sudden popping up. It says, if a patient progresses well on adjuvant IO or TT, what is your next choice of therapy? I think a lot of things go into that answer. I think that each case is a little bit separate. So I think there's not a set of guidelines. Some medical oncologists would go to clinical trial options. Some folks would switch to, if you have the BRAF mutation and you had IO, they would switch you to BRAF therapy. I think, unfortunately, Ranjit, we can't really answer that question specifically for you. It depends on where you progress, if surgery is an option, if radiation is an option. So I think that's a very specific, unfortunate.
But I do think we feel very strongly, I think at both of our institutions, clinical trials are always an option. So if you don't have the facilities where you live for that, you definitely can use AIM, or you can use other resources to find clinical trials that potentially you could be eligible for, and find out where they are in relation to where you live. So I think in that setting, clinical trials are always what we would consider. So.
Yep. And, outside of AIM, there's, clinicaltrials.gov, you can actually put in extremely specific search criteria so that, you can really find a lot of really good information there. AIM does have a couple links to actual folks that will help you find clinical trials. I will help you find clinical trials as well, as part of the Ask an Expert line. Harvey Hellerstein from wants to know, what is the latest research projects that are taking place at the Fox Chase Cancer Center?
Yeah, well, we have tons. So we're a nationally, a recognized cancer center, NCI funded. And so we have tons of research projects related to melanoma, though. We have all different levels of research related to melanoma. So there's basic scientists that are looking at different microenvironments, so kind of tissue around the melanoma and how that grows, responses or how we can improve the response of immunotherapy to treat melanoma, or how we can improve targeted therapy like the BRAF inhibitors, or identify other targeted therapies that we can use to treat melanoma. So there's a lot of basic science that we do. There's a lot of clinical trials that we're doing, looking at both advanced stage non-metastatic melanoma, advanced stage 2C melanomas, adjuvant therapies for stage 3 melanomas, stage 4 melanomas. We have multiple injectable trials, so patients who have in-transit disease or nodules that we can resect or that we can inject. We have injectable trials in combination with immunotherapies. And then we're doing outcomes trials, just looking at overall outcomes in patients in melanoma and kind of how patients are tested nationally for personalized medicine and molecular profiling. So there's a lot going on that's really exciting and really keeps all of us exceedingly interested in this space. It's very, very exciting. I always like to, there's patients that I see now that when I started, unfortunately would have died, that are alive now because of where we are. And it just makes us so excited about what we do, that we have these patients that we can, and even in the metastatic setting, when we can say that we have patients that we think that we can cure, which we never, ever thought we would say. It's really, really exciting.
So I think the whole profile of melanoma over the last 5 years has changed. I started practicing medicine in 2005 when we had interferon and IL-2, and that's it. So now things are amazing in comparison to that. One of the questions, and I don't know if you'll be able to help with this, but is there a medical center who specializes in mucosal melanoma and like the surgery specifically for mucosal melanoma?
Sure. I think all of the national cancer centers. So mucosal melanoma can occur in multiple sites in the body. So it can be a nasopharyngeal, it can be in the lining of the bronchus or lungs, it could be in the vulvar and vaginal region or anorectal. And these are very, very rare melanomas. And so I don't think that there's any place that has like the biggest experience or sees tons of these. However, I think all of the large cancer centers do have what I would consider a moderate volume and experience treating these. And so if you could, these are definitely types of melanomas, one that can be very aggressive. And there are clinical trials that we have open and others related to mucosal melanoma. So you definitely want to go somewhere where, I think the key is going somewhere that has experience treating them. And all of the NCI funded, the designated cancer centers would be a center, have that experience treating mucosal melanomas. I don't think that there's one place that just sees them all. I think we all see them. They're just very rare.
Yeah, that's how we kind of have the similar experience with like ocular melanoma. It seems like all of the, NCI funded melanoma centers have their fair share of ocular melanoma. It's just much more infrequent. And so you don't, there's not a freestanding building somewhere that sees all of those people is essentially what I don't, see. It seems like we all kind of have our own clinical trial groups and surgical oncologists that deal with this kind of everywhere, but the bigger centers I think are helpful.
Yeah, I would agree with that.
Dr. Farma, I think this has been really, really informative, not only for our patients, but for me. I really appreciate that you came on and were able to provide us all with so much information. I think, one of our goals really is to just make this a lot less scary by educating folks. And so I appreciate all of the time, that went into this and everything.
Absolutely.
Hopefully.
Thanks for having me. It was, I think, really great questions. I think the best thing is communication. I think you have to have an open relationship with your providers, and especially in times like this, because like I said before, we don't have all the answers. This is something that none of us have ever experienced, and we're kind of all in it together. And so we just have to, I think the best thing is having open communication and discussing options and what's best for you, and with your family discussing, and your provider. So thank you for having me. I appreciate it.
Oh, of course, it was a pleasure. I hope we can talk to you again very soon. I hope that you stay safe where you are, and have a wonderful evening, and we'll see you soon.
You too. Okay. See ya.
Bye then.
Bye, everyone.